Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the PALM series, which is practical aspect of lab medicine. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can join to access all lecture related information. We also have a Google Drive where you can access all the PDFs of our lectures. And these are the disclaimers. Here we would like to emphasize that we do not sponsor any company, group, or organization. Reference to any particular brand is purely at the discretion of the presenter, solely done for understanding and explaining the subject. We do not subscribe to any particular brand. And we are with phase 3, which is a recorded pathology lecture. And today we have PALM-04, which is basic principles of quality control. And we are streaming from RG Kaur Medical College and Hospital, Kolkata. And to talk on today's topic, we have Dr. Sharmistha Choudhuri. She's an MBBS MD from AIIMS, New Delhi, with Diploma in Health and Family Welfare from New Delhi. Presently, she's an assistant professor in the Department of Biochemistry, RG Kaur Medical College and Hospital, Kolkata. She's also the Assistant General Secretary of Association of Clinical Chemistry and Lab Medicine, member of the Editorial Board of Journal of Applied Biochemistry and Lab Medicine, member Medical Education Unit of RG Kaur, member Scientific Committee of RG Kaur Medical College and Hospital, technical assessor for NABL, and she has published various articles in national and international journals. With that, I would request Dr. Sharmistha Choudhuri to start her lecture on basic principles of quality control. Over to you, ma'am. Thank you so much.
Good day and welcome once more to the second lecture of the PALM module. Our previous talk was on the good laboratory practices. In continuance from there, I, Dr. Sharmistha Choudhuri, would now like to take us all through the basic principles of quality control, which we all know is an integral part of the functioning of any format of good laboratory practicing. Now, in my previous talk, I had shown these three pictures, if you had perused that. So, just a recap and a rehash of what we had covered in the last lecture. These three pictures, they represent the very best of quality in their chosen fields. A Rolls-Royce car, a Rolex watch, and the Dom Perignon champagne are literally at the top of their heap so far as quality is concerned. Now, achieving that level of quality where literally the name itself is sufficient and no advertising, no propaganda is needed to sell these products, that itself speaks volumes for the immense hard work and labor that goes into ensuring that level of quality. The same we can replicate in our day-to-day lab practices also. So what are our learning objectives? I hope that by the end of this session, you would be able to have a basic understanding of the key principles of quality assurance and quality control, and we would be able to peruse through the different components of internal as well as the external quality control or the external quality assurance as we speak of it, or the EQAS. Now, how important is quality? Quality is literally the building block or the foundation on which the clinical laboratories are managed on a day-to-day basis. And this is actually based on a three-tiered principle of QM, that is quality management, QA, that is quality assurance, and QC, that is quality control. Now, the term total quality management is a very important concept so far as quality principles are concerned. What is it? Basically, it is nothing but a continuous process of quality planning, quality laboratory processing, quality control, and quality improvements. And all these encompass the goals and objectives that go behind quality requirements. So it includes QP or quality planning, QLP or quality laboratory processes, QC or quality control, QA or quality assessment, and QI or quality improvement. So next we come to the elements of quality assurance. What does that involve? It involves the PDCA cycle. PDCA stands for plan, do, check, and act. Plan includes quality planning or QP. Do includes QLP, that is quality laboratory process. Check involves QC and QA, that is quality control and quality assurance, and act involves quality improvement or QI. So for assuring quality, the first and foremost, we have to plan our activities, what we intend to do, that is plan the level of quality we want to ensure. Next, we have to set into act some processes which would be involved in doing the stuff. So that would include the QLP. Then whatever activities we do, we need to check on those. So that includes the QA and the QC. Absolutely continuously this must be done. And whenever there is any fault, which we discussed in the last module also, we have to set into play the corrective action, preventive action module, or the CAPA process, and that is actually another term to ensure quality improvement or QI. Now the WHO has defined quality as accuracy, reliability, and timeliness so far as the laboratory quality is concerned of reported test results. The lab results must be as accurate as possible, all aspects of the laboratory operations must be reliable, and reporting must be timely in order to be useful in a clinical or public health setting. So the basic definition aims to reduce wastage of resources, finances, and time, and in consequence can avoid these negative impacts of unnecessary treatment, treatment complications, failure to provide the proper treatment, delay in correct diagnosis, and any additional and unnecessary diagnostic testing. Now, in the last module, we discussed that quality lies in every step of the way, starting from the pre-examination or the pre-analytics to the analytics or the examination and the post-examination or the post-analytics. Now, since the pre-examination part has already been dealt in a separate lecture of the PALM module, I will straight away go on to the examination and post-examination areas of quality assessment. So what are the chief aims of quality control? We discussed this, that it is to actually get the right aids. That is the most important way of assessing that our quality is in the right place. Provided we get the 8 rights, that is the right test with the right specimen, with the right patient preparation, with the right test method, with the right reporting of results, with the right reference values at the right time, and at the right price. So quality can broadly be divided into two segments: the internal quality control and the external quality control. Internal quality control involves quality elements with respect to a single laboratory, and it involves those activities which are meant to ensure achievement of desired quality within the lab. And this can be made through 3 P's. What are the 3 P's? Plans, policies, and procedures for improvement of the performance parameters. Now, there are many components to internal quality control, but the most important pillars on which it actually rests include the following. One is presence of committed staff. Without having sincere personnel who are dedicated to maintaining quality, nothing can be achieved. So that is the first and foremost requirement, to have sincere and dedicated personnel. Secondly, of course, facilities and resources like space, equipment, financial aid, those are very important. The staff who are going to ensure quality must be educated and skilled enough. Then comes technical procedures, which involve control of the pre-analytical, analytical variables, and ensuring the analytical quality. All of these are conglomerated into developing a problem-solving attitude, which is dedicated to identifying errors and rectifying those errors at the earliest and ensuring that these errors do not recur as much as practically possible. So we come to various analytical variables that are part of the quality process. I am not discussing the pre-analytical variables where quality assurance is very important because this has already been discussed. So we will straight away skip on to these analytical variables. And they include a plethora of components like the choice of the analytical methodology, the way the analytical methodology is documented, how well we have established reference values, how well we are controlling the inventory of materials. If we have introduced a new method, are we monitoring the changes? What are our strategies for ensuring the performance or the analytical quality? What type of reference materials and calibrators we are using, so on and so forth. Now, there are many definitions here which are of primary importance so far as analytical performance parameters are concerned, or in other words, what we often describe as the performance qualification of our testing. So, calibration, trueness, accuracy, precision, these are few terms which we have to know. First of all, calibration. Calibration is nothing but a relation between the instrument signal and concentration of analyte. Very simply put, it can signify that if a machine gives a particular absorbance, then the concentration of the substance giving that absorbance would be such and such. This is slightly different from trueness. Trueness is defined as closeness of agreement between the average value obtained from a large series of measurement and the actual or the true value. Now, what is accuracy? Accuracy is closeness of agreement between a single result of measurement and the true concentration of the analyte. In this way, it differs slightly from the definition of trueness. And what is precision? Precision is nothing but a measurement of repeatability and reproducibility. It is actually the closeness of agreement between independent measurements obtained under stipulated conditions. And this precision, we say, shares an inverse relationship with the coefficient of variance, which we will come to later. Now, which one are we to opt for? Are we to opt for accuracy, or are we to opt for precision, or are we to opt for both? This bullseye diagram is very famous, and I think many of you may have seen it. The first one describes a condition with low accuracy and low precision. That is, if the bullseye, the target, is meant to be the accurate most point, then we can see that there is neither accuracy and all the bullets have gone haywire, one here, one there. So it is a low precision also. In the second case, the targets have all come to a single place, clustered together, but nowhere are they near the bullseye. So it is low accuracy but high precision. That means a mistake is being made and the same mistake is being repeated again and again. The third scenario is that of high accuracy and low precision. This is slightly unusual in occurrence. It means that the values are close to the true value somewhat, but the repeatability is poor. Say, for example, the true value of glucose is 100 milligram per dl. So one time we are getting 95, another time we are getting 101, another time we are getting 100, the fourth time we are getting 98. So they are somewhat close to 100. One value is even 100, but they are not very much close to each other so far as individual values are concerned. Now, in the last case, say the true value of glucose is 100 milligram per dl and our 5 measurements are 100, 100, 100.1, 100 and 100. So values are very, very close to each other and also extremely close to the true value or the target value. So this is the condition to opt for. This is the condition to strive for, a condition of high accuracy and high precision. And this is what we must all aim to achieve. The idea is to achieve this. It is difficult and this is almost a perfect scenario, and not always this happens, but we can all strive to come somewhere close to it. Now, coming to reference materials and calibration. Now, what are reference materials? Reference materials, or calibrators as they are commonly known, they are nothing but materials or substances, one or more, whose property values have been sufficiently homogeneous and well established for calibration of an apparatus, assessment of a measurement method, or for assigning value to certain materials. And when such a homogeneous material is accompanied by a manufacturer's stamped certificate, when it is, we say, traceable to a higher order standard establishment, so that type of a reference material that we usually use in our labs, that is known as a CRM, or a certified reference material. And the working material that we derive from these reference materials or from these certified reference materials, which we are using on a day-to-day basis to graduate or calibrate a particular instrument or to standardize a particular measurement procedure and compare it with our test results, that is known as the calibrator. It is sometimes also known as a working calibrator. Now we come to the very important concept of traceability. Traceability is the focal point between two extremes, one our observed value and the other the true value. This is a term which is confined primarily to the calibrators, to the reference materials, but nowadays is also being extended to control materials or the internal quality control materials. For practical purposes, calibrators, they come with a traceability certificate, and the value which our calibrator gives on our machine is supposed to be in sync or at par with a calibrator which has been standardized using a higher order method, and that is called the traceability chain. For example, serum creatinine in most labs is estimated by the kinetic Jaffe method. Now that is done using calibrators for this particular method. Whatever value the calibrator is giving us with kinetic Jaffe must be in sync with a higher order calibrator or with a secondary reference material which the manufacturer standardized by a better method, a more specific method, say the enzymatic creatinine method. Now, even that particular reference material was traceable to an even higher order primary reference material, which was standardized by the gold standard technique for serum creatinine estimation, that is the IDMS technique or the isotope dilution mass spectrometry technique. So calibrators which we are working in the base and the baseline level in the lab must be accompanied by a traceability certificate that ensures that the value provided by our working calibrator is in fact in sync with the value provided by the highest order calibrator. Then only we can with great surety report the unknown patient test values against our calibrator. Nowadays, like I said, this is being extended to the internal quality control materials also, which are coming with a traceability certificate, which are following the accuracy testing just like the reference materials. So that day has also come into vogue. Now, coming to the control materials. What are the control materials? They are nothing but a device, a solution, or a lyophilized preparation, or even a pool of collected human or animal specimen, or artificially derived materials which are intended for use in the quality control process. So we have to understand the basic difference between a calibrator and a control. So what is the key difference? Calibration is simply a concept of correlation of instrument signal and concentration of analyte, and it is an important tool to ensure traceability. Barring a few exceptions, as of now, vast majority of controls is a concept of analyzing specimens whose concentrations are known, simply following calibration, and it cannot be used to establish traceability. Rather, we first need to run our calibrators to see how far our machine goes in giving the accurate or the value as close as possible to the true value. After that, we would be running control materials which are usually of the same metrics as that of the patient samples, unlike the calibrators, which are very pure preparations and usually never of the metrics as that of patient samples. Controls would have assigned values which would be reported by the machine in an accurate manner, provided that the calibration of the machine was done properly with the calibrators or with the reference materials. So we always do calibration first, and after that we run the controls and the values are documented and analyzed. So what are the few important points we need to remember with respect to controls? Controls have to be run at the beginning of each shift, after calibration, whenever reagent lots are changed, after an instrument is serviced, and when patient results seem inappropriate. In all these conditions, we must run the controls. And there is another term which is often confusing, known as standard. So standard is also a substance of constant value, but this is more of an in-house preparation of a calibrator, and we should not confuse standards with controls. Standards are nothing but in-house calibrators of different concentrations which are made in the lab itself. They generally do not have any traceability, so to speak, and they are very different from controls because the metrics of the standard is again different from the metrics of the patient sample mostly. In some cases, bracketed QC may be run after every 25 to 30 samples, but this is really not feasible because it is costly. Sometimes when commercial controls are not available, then pooled sera may be used as an alternative, but there are health issues to consider. The pooled sera must be tested just like commercial controls are, but with pooled sera usually they are pulled from patient samples directly. So in some cases when controls are not available, we can go for that. So what are the chief properties of control material? First and foremost, it is very important to remember that it is the same matrix as the patient specimen. Secondly, there should be minimum vial to vial variability. They must be stable long term. They can come or they may not come without acid ranges, but usually the ranges are given, and usually we run them in multiple levels like level 1, level 2, level 3. Level 1 may be subnormal, level 2 may be the normal or the within the biological reference interval limit values, and level 3 is usually the abnormally high ranges, but that may vary also from manufacturer to manufacturer. But the values or the ranges for level 1, 2 and 3 would be different. Not necessarily that level 1 is below normal, level 3 is above normal, that may be different, but each level would have a different range, would have a different mean, would have a different standard deviation, and we'd come to that. So how would we ensure the analytical quality? First of all, our control materials need to be really stable. And secondly, provided they are stable, after run, we have to assess how they have run using quality control charts. Now, what are the quality control charts? This is the most common method for comparison of values observed for control materials with their known values. And the charts have lines denoting upper and lower control limits. Control limits are usually calculated from the mean and the standard deviation, which is obtained after we make a series of measurements. And usually we set the limits to either plus minus 2 standard deviations or plus minus 3 standard deviations. Most commonly, we use plus minus 2 standard deviations, which denotes that 95% of the values would come under it. Plus minus 3 standard deviations takes into account about 99.7% values. Usually that is not done. So there are some relevant statistical concepts which we have to understand. The first being Gaussian distribution. Now Gaussian distribution is usually what we call a normal distribution, where the distribution of values forms a symmetrical bell-shaped curve. Now this is important when we are trying to verify the majority of the biological reference interval values. Say a manufacturer has given the blood glucose normal biological reference interval as 70 to 100 milligram per dl. Whether that 70 to 100 is applicable to our population or not, for that purpose we have to take at least 20 is required for verification. Of course, for validation purposes the number is very vast. So but in the on a practical scale, a lab can easily verify its BRI or the biological reference interval which the manufacturer has provided. The manufacturer has just given a range which is for their particular machine, but whether that particular range is applicable to the population to which the lab caters to, depending on the geographical location, the demographics, it is advisable that the lab collect at least 20, preferably more, from apparently healthy population. These samples are collected and then the values are plotted, and if the values they fall under a symmetrical bell-shaped curve, then there is a normal distribution, and to verify the BRI, at least 90% of those values must lie within the 95% confidence interval limit, that is must be within the plus minus 2 SD with respect to the mean value. Now, what is standard deviation? This is a fairly common concept. This is nothing but a measure of dispersion from the target mean, and it is defined as a square root of variance. Now, the more important term is a coefficient of variance. This is nothing but a measure of dispersion from the target mean, and this is actually a ratio of the standard deviation by the mean expressed as a percentage. So when we are using the same instrument but different methods in the same instrument to observe variance of values, when we are using two different methods in the same instrument, the standard deviation is preferred, but the CV percentage is more preferred when we are going for different instruments or kits. Now, what are the important points to note with respect to QC charts? The most important thing is to judge from the chart whether the run is in control, and that is whether it is acceptable or not. And that involves us being able to identify errors which are either random errors or systematic errors. Now, what is a random error? A random error is unavoidable and unpredictable error. It can be due to a wide number of factors like wrong pipetting, inadequate cooling, inadequate or improper reconstitution, and it increases the probability of false rejection. So the problem lies in repeatability or a problem in precision. This is totally different from that of systematic error. Now, systematic error is an avoidable and predictable error. It usually arises from faulty calibration. So it is a problem of accuracy. There is inaccuracy because due to this error, the value which we are getting is deviating away and away from the mean. So it is, if this is a rejection, it is a probability of a true rejection. Based on the concept of random and systematic error, we have a few rules known as the Westguard Rules, which we'll come to later. These rules are based on the quality control chart, which was designed by Levy-Jennings. So this is a prototype Levy-Jennings chart. What is it? Usually we take the mean plus minus 2 SD. In this chart, the plus minus 3 SD has been given. It involves running a series of control materials at different time points, as we can see, that is plotted in the x-axis, say on day 5, day 10, day 15, day 20, continuously every day the controls are run. And the value of the control materials, that is plotted on the y-axis. And say for 30 days that particular control has been run, so there are say 30 points minimum. If one level has been run, if two levels have been run, say there are 60 points. Now the values are plotted on the y-axis against the run date on the x-axis. The mean value is taken and a line is drawn denoting that particular mean value. The standard deviation from the mean is also noted, and either plus 2SD and minus 2SD are set as the limits, or as in this case, plus 3SD and minus 3SD has been set as the limit. Now, whatever limit we have set, we have to follow that limit. If we have set plus minus 2SD, then we will consider our control to be acceptable or the run to be acceptable, provided all the points are within the plus minus 2SD limit. In case it is not so, it is an outlier, there has been an error or a warning, and accordingly we may or may not need to take some sort of corrective action, which we will see in the coming slides. So, coming to the different types of error once more, there can be two types of error which can be derived from the run of the quality control materials. In the Levy-Jennings chart, one can be an error in precision, that is a random error which has just occurred, as the name suggests, utterly randomly, in a random fashion, in a single time point. This is, say, a random error. And a systematic error is an error which has occurred due to constant deviation of values one after another from the mean value, so that the values after every run are deviating more and more away from the mean. This deviation of a value away from the mean is what is known as bias, what is known as inaccuracy, and this constitutes a systematic error. Now, based on the types of errors that can occur, either a random or a systematic error, there have been some rules devised by Westguard and Associates, which are very useful for interpreting the quality control data and what we use on a daily basis to identify errors and correct them as needed. So this procedure, it just involves having Levy-Jennings chart with the limits set at plus minus 1 SD, plus minus 2 SD, and plus minus 3 SD, and deciding which will be our limit for taking a decision. So the rules. First and foremost, the 1-2S rule. 1-2S means that one control observation has either exceeded the mean plus 2 SD or has fallen below the mean minus 2 SD level. This is considered to be only a warning rule. No action needs to be taken at this point, but one is warned so that one can observe and see if this error is repeated or a worse error is occurring in the next run. So this is just a warning rule, just needs observation, nothing more. The second one is rule 1-3S. Here, one control observation exceeds the mean plus 3SD or the mean minus 3SD. This is a random error, but it requires us to take some corrective action that may be in the formation of calibration, a recalibration may be required, or we may need to reconstitute our control materials, give a rerun. In short, some corrective action has to be taken, and this is considered to be a non-conformity so far as quality control run is concerned and needs to be recorded also. Now the third one is the 2-2S. So this involves two consecutive control observations exceeding either the mean plus 2SD or mean minus 2SD limit. So whenever two consecutive observations are falling on the same side of the mean, it means that there is a problem in accuracy. It is an inaccuracy type of error where there is deviation slowly happening away from the mean. So it is a systematic error and it must be corrected through recalibration. The rule R4S means one observation exceeds the mean plus 2SD and another exceeds the mean minus 2SD. Both have occurred simultaneously. This is also a random error and needs to be corrected. Now, whether it is a random or a systematic error can be very easily identified just by looking at the Levy-Jennings chart. If the two values are on opposite sides of the mean, then it usually indicates a random error. However, if they fall on the same side of the mean, that is usually a systematic error. The rule 4-1S means 4 consecutive observations exceeding the mean plus 1 SD or the mean minus 1 SD. This is a systematic error, obviously, as the 4 values are lying on one side of the mean. However, this is now not considered to be an error when we are taking the limits to be plus minus 2 SD. Whenever we are seeing this, we call it a bias and we do the necessary recalibration. We do not identify this as an error per se. It is only an error if our decision is taken at plus minus 1 SD. Otherwise, this is also a place where we just identify the bias and take the necessary correction for that bias only. The rule 10x is now absolutely obsolete because it involves 10 observations lying on any side of the mean. It is a systematic error undoubtedly, but we will never allow our runs to go on being on the same side of the mean for 10 consecutive runs. The corrective action would be taken long before that. So this is now an obsolete rule and no longer in vogue. So apart from the analytical quality assessment by internal quality control materials, there are other means of assessing the analytical quality using patient data, such as through limit checks, through delta checks, through intra-lab duplicates, through correlation with other lab tests, through clinical correlation, that is between the testing and the clinical condition of the patient. So individual patient results can also be used to assess analytical quality. Apart from this, before we go to the external quality assurance, I'd like to recapitulate that in the previous talk, we talked of many ways of assessing performance qualification. The internal quality materials that we run, the CV percentages need to be calculated, and we have to see whether there is any deviation constantly happening, whether we are getting a high CV percentage value. Moreover, the second aspect of today's talk, the external quality assessment, is a very, very integral part of performance, which actually signifies how accurate our test results are when we compare it with others of outside labs. So the total error assessment, taking into account the imprecision from our CV percentages and the inaccuracy from our external quality assessment results, that accounts for the total allowable error. Apart from this, we can go through other processes like verifying the measurement range, the entire range across which our examinations are valid. Say our machine has a measuring range of 5 to 700 milligram per DL for blood glucose. Whether the machine is actually able to report to that extent, that I have discussed. So in the previous module, so far as linearity checks were concerned, where we dilute the patient sample and we see to what extent the diluted values can be reliably given by the lab instrument. And second thing is to verify the analytical measurement range of the machine simply by noting down patient values which are low values, values within the biological reference interval and very high values, and seeing whether the machine is able to report those values. Assessing for carryover, using a low value sample followed by a high value and again rerunning the low value sample and seeing the difference between the two low value samples, whether the high value sample has contributed to some measure of carryover to the low value sample. So these are so many ways, the list is endless, by which we can keep on assuring the quality. So we will, there is no end to it, we can go on discussing those, but just I am telling these things so that we can keep this in mind whenever we are going to work on these things in our own lab. Now without further ado, we will go on to the external quality assessment. So what is external quality assessment? This is done for maintenance of long-term accuracy, and it involves sending of either the QC material or the patient samples to a central agency. Usually QC material, if it's sent to a central agency, then that involves traceability of controls. But in our settings, we do not do that. We do not do that for control materials. What we actually do is for patient samples. So we do not actually send our patient samples. Rather, there are two ways of doing it. One is to participate in a program where commercially available materials are sent to us and also to others participating in the program. That is known as a participation in a commercial PT or in a commercial ICAS program. In the absence of a PT provider or an ICAS material provider, we can take our patient samples and send them to two outside laboratories and compare our value with those two other labs. That is known as inter-laboratory comparison. Both ICAS and inter-laboratory comparison are in fact part of what is known as proficiency testing or PT. In the absence of commercially available ICAS materials, usually we can go for an inter-laboratory comparison. So if the commercially available ICAS is there, the agency, they send their materials, we test them and resend them back to the agency to assess the validity, reliability, and most importantly, the accuracy of results. So it is said that either the controls or the material which are sent by the external agencies, all the participating labs, they analyze those, they run those in their machines. Results are tabulated monthly. These are all monthly programs, and they are sent to the sponsoring group for analysis. And the summary reports are prepared by the sponsor and distributed to all the participants. How are they distributed? Usually, the participating lab, they have a particular value, and all the labs which are coming under that same group, they are called a peer group. There is a common mean for that. So all the values of the participating labs, the mean value is taken, the standard deviation is calculated, and what is known as the Z score. That is the value obtained by our lab minus the mean value upon the standard deviation. That is calculated. And ideally, the Z score should be between plus minus 2. If it is either less than minus 2 or more than plus 2, it is a error and that needs to be corrected. So every lab will send in their sample results once a month to their PT provider, and they will see where they stand with the rank given as per their Z score. So this is the way that a lab can know how well it is not only functioning internally, but where it actually lies, where it actually stands, so far as the bigger picture, the more global picture is concerned. Now we come to the third part of today's talk, without which the talk on quality control remains incomplete, and that is the concept of laboratory accreditation. So this is nothing but a recognition given to a lab as delivering accurate and reproducible results. And it is a recognition of compliance with the quality of standards and norms as required. So what are the roles of all the personnel in the accreditation process? There has to be a laboratory director involved, technical personnel, and a quality manager. A laboratory director has a lot of roles and responsibilities. He is in fact the spearhead of the accreditation and certification process. He implements all the standards and he is ultimately responsible for the overall functioning of the lab and overall assurance of the level of quality which the lab is claiming. He delegates the responsibilities to his quality manager, who explains all the terms, all the necessary work that needs to be done, and helps in organizing and preparing the quality module. And the work ultimately is carried out by the technical personnel, the staffs, the consultants who are aware of these requirements, and they contribute by working together in meeting these standards. They are aware of the assessment processes and they prepare for the routine assessments on a regular basis. So there are many accreditation bodies. The common ones, the most popular ones, is the International Organization for Standardization, or the ISO. There was the Clinical and Laboratory Standards Institute, or the CLSI, the European Committee for Standardization, the World Health Organization, only to name a few. Now there are some definitions with which we have to become privy when we are part of the accreditation process. The first one is the licensure. What is licensure? This is the granting of the ability to practice, provided most often by a local government agency, usually based on demonstrated knowledge, training and skills. Say one is licensed to practice medicine. So that is given by a local government agency. Now certification. License is given by a local body to the lab that, okay, you are allowed to open a lab and deal with patient samples. Now certification is a procedure by which a third party gives some written assurance that a product or a process certifies or conforms to specific requirements, say a traceability certificate given by a manufacturer. And ultimately, an authoritative body that recognizes that a particular institute or body or lab or person is competent to perform the specific task coming from these authoritative agencies which we just discussed about in the previous slide, those are the accrediting bodies, and that process is known as accreditation. So what is the pathway to accreditation? If the lab is opening today, they have to get the license, that is licensure has to be done. Then they have to get all the quality policies, processes in place. They have to get certification from different agencies, say from their manufacturer with regard to traceability, from the pollution control board, from biomedical waste management. For every nuances have to be covered in certification. Armed with these certificates, they can claim to be a reference laboratory, they can claim to be an accredited laboratory as per international guidelines, as per international standards. For that, they have to apply for accreditation to the accreditation agency of that particular zone or that particular country. So what are the elements of the accreditation process? Very simply, there is an accreditation body who have with them a set of standards which is universal to all. Those standards will be adopted by a group of individuals who are known as the assessors, when they will visit the user laboratory and see if the laboratory is complying with the elements of those standards. So criteria which is required to be fulfilled by an accreditation body itself, that we have to know before it is considered to be competent enough to assess others. Number one, it must be approved by the higher authorities. So say the National Accreditation Board of Laboratories, the NABL, that is ISO certified. So that has been approved by the Quality Council of India as an accreditation imparting body or as an accrediting body. So it has with it knowledgeable and competent staff. It follows the set of standards. It is known to be objective in their assessments, and that is the agency to which the labs are applying for to get their required accreditation. And there are some terminologies which we have to be savvy with. Number one is consensus. Consensus means agreement, so it represents a general agreement in the absence of any strong and compelling objection. Then normative statement. Normative statement means it is required and it is an essential part of the standard, and it uses the word shall, meaning it is mandatory. Informative statement is an information, and often it is given as a note, as something that is advisable or precautionary, or it can also provide some example. What is compliance? Compliance means that some activity or some doing, some particular process, it meets both the text and the spirit of a requirement as defined in the standards. What is non-conformity then? That means it is a failure to fulfill the requirements of that specified process, service, or structure, whatever the case may be. And this may be either major when it is a complete failure, or a minor when it is a partial failure. And verification of conformity or the lack of it, that can be confirmed only by examining the said evidence. So it is very important to remember that accreditation does not guarantee success. It is only a single step in the long journey of quality assurance. So accreditation is a boost to the lab because it gives an impetus to the lab for continual improvement, error reduction. Ultimately, that leads to better lab service, enhanced customer satisfaction, and all in all, a very desired and satisfactory level of quality management. So they say it is an accomplishment to get accreditation, yes, but it is an achievement to maintain it because it has to be maintained year in and year out. Thank you. That was all for today. Now we'll be back with one more lecture of the PALM module in due time. If you have any questions, you can please address me in the comment section, or you can email me to my email ID. I'll be very happy to take them. Thank you all and have a great day ahead.